So welcome everybody to the latest in our quarterly Q&A sessions. This one's on feeding experiences and oral aversion. My name's Drew Bailey. I'm the new-ish chair of TOFs, having taken over earlier this year from Duncan Jackson, who's also co-hosting with me tonight. I have 3 children. My oldest is 19. He's my TOF child, so that's my connection with TOFs. And I'm very interested in the topic tonight. And it was a while ago, but I can remember the own experiences that we had with feeding, and lots of the questions that have been submitted tonight are very reflective of my own experiences. So really interested to hear what Maya's got to say in response to some of the questions. So as I said, Duncan's on the session as well. Maya, Asir, very happy to be joined by you tonight. Delighted to have you here. Obviously, I'll let you introduce yourself shortly. You're obviously the as it said on the slide earlier before the call, the lead inpatient speech and language therapist at Evelina London Children's Hospital. So really interested to hear what you've got to say in response to the questions tonight. So we've had some really good questions submitted in advance, and Duncan and I will take it in turns to go through those as we start off. And then I think everybody's aware, as usual, there's an opportunity to ask questions live as we're talking. And then once we've been through the sort of pre-submitted questions, we'll turn to the live questions in the chat. So Maya, I don't know if you just wanted to introduce yourself briefly, and then we'll crack into the questions.
Yeah, sure. Thank you, Drew, and thank you for having me tonight. So my name is Maya. I'm a speech and language therapist. I've been a speech and language therapist for 18 years, maybe. I've always worked in paediatrics and currently work with inpatients and the neonatal unit in Evelina London Children's Hospital.
Great, thank you. Right, so let's kick off with the first question that we've had pre-submitted then. So this question is, how can we prevent a long-term food aversion and encourage our baby to try new things?
So lovely question. First thing I think and say is positive experiences. It's really important. These early feeding experiences are really important, and they can impact the child's relationship with eating and drinking as they grow. And we have evidence of this in babies who are born preterm, babies born with cardiac conditions, babies who have difficulties with feeding early on, but also that there is a lot of emphasis and stress on feeding early on, and how that can alter the relationship they have with eating and drinking. So some of them have smaller food repertoires, or associate stress with eating. So it tells us something really important about those early experiences, and the stress that's related, and how formative these experiences can be. And when they're little, with babies, we can take advantage of the neuroplasticity that they have. So lay down pathways that are positive in the brain and associated with eating and drinking that are positive and have positive relationships. So simple things that you can do is involve the child in the food. So involve in the shopping, food shopping, make choices about what to eat, and involve them in preparing food, handling the food. Talk about the food when you're sitting at mealtime. Describe the properties, what it feels like, the variety of it, how you can prepare it. Show them, that whilst you're eating, you can exaggerate, biting, chewing, showing them what it looks like, talk about it. All of these things are really helpful to create that experience. In terms of introducing new things, it depends. This might be that it has to be gradual. Sometimes it's about exposure, a gradual approach to introducing new foods. Sometimes if it's difficult to introduce something new, you might want to change one thing at a time. You might want to introduce a small amount of new food, like at the dinner table, maybe not every day if it's stressful, maybe every other day. We just remember that eating is a really complex task. And what we want to do is build up their trust and build their confidence in the experience. And as hard as it sounds, and I know obviously easier said than done, reducing the stress around eating, keeping the experience positive, with low stress, low emotions related to food, and just thinking that you want to counteract all the negative experiences or any negative experience that they might have had with lots and lots of positive experiences.
Okay, interesting. But don't want to preempt too much, but I know later on there's a question around distraction techniques. So interested to see how that involvement in food point and focusing on the food plays against that distraction technique question. But yeah, we'll I won't spoil anything more for later on. So Duncan, do you want to?
Yeah, good evening, everybody. And good evening, Maya. How do you overcome oral aversions in toddlers, and can these food aversions be reoccurring?
Good evening, Duncan. Yeah, so I think it's really important to understand the aversion, right? What is the aversion to? Is it the texture? Is it the taste? Is it the experience in general? Is there a restriction to particular foods? Sometimes it's the color, or there are other reasons. And also the reason. What is the reason for the aversion? Obviously, a child with TOC or OA, their feeding behavior and their feeding function will depend on their whole journey, right? So that starts from the repair itself, how things are functioning, what the esophagus doing. Are there any other associated difficulties, or maybe not associated, but alongside? Do they have airway malacia? Is there a stricture? Is there reflux? All these things that we, consider and talk about, and parents are very well aware of. What's the motility like? Is there a swallowing difficulty appear before it reaches the esophagus as well? So in addition to all of these, there's experiences that they have along the way, as I mentioned. Has there been any trauma, both for the child and the family? That's really important. And then there is the child's development. How are they doing with their development? What are they like? And their personality even. So eating and drinking, as I said, is a complex activity. So we need to integrate lots of our body systems to do it, but also in addition, the environment that we're in as well. So it can be quite complex. And then you have toddlers. Tricky age in general. There's a big developmental shift in between 2 and 3 years. That comes with increased independence, and there's a higher emotional load. Toddlers can be picky with foods anyway, at a typical developmental stage. So it's really important to just break down what's actually happening with the child and why, if we can. So, for example, is it the history potentially with the positive experiences? Has that led to some avoidance of eating, of being defensive, being worried? Is this a sensory aversion? And then again, what's happening at the moment with the function, right? So, is there reflux? Is there a residual stricture or a recurrent stricture? So what's happening there? That's another element. Developmental factors as well. So, and I mentioned personality because some experiences can impact some children significantly, and some might not impact other children. So, and you we learn that about these children as they grow and realize that some things are just part of their personality. They might be more flexible, they might be more rigid, and that plays a big part of it. So I think overall understanding the type of aversion and the reasons for the aversion will help us know what the best approach is. So for example, if it's sensory, then it might be techniques about exploring food, and again, what it looks like and feels like, and all of that. But there are general approaches that you would use generally, universally. So for example, having consistent mealtime routines, having a clear start and finish to the mealtime, limiting the time that the meal is taking to half an hour, eating together, again, reducing the pressure, the emotional weight on food. So for example, not using it as a reward. And obviously, if there's any structural issues or any medical issues at the moment, we need to look at managing these. And so some things that we can't manage, we know that children and young people start to just make adaptations to, right? And I think probably we hear this a lot from children who are older who have just learned to adapt. So, and in terms of the recurrence, we all know, I think the journey is very up and down. The progress is not going to be linear, so there might be some recurrences of that depending on what's happening with a child at the moment. But sometimes it might not be recurring, so it completely depends. So yeah, I think again, just focusing on whilst they go through this journey as much as we can, keeping it positive, and then hopefully working with the teams that you can access. So speech and language therapy, dietitian, maybe occupational therapist as well, who has experience in these areas.
Yeah, that's great. Thank you. So some really good advice there. And obviously, yeah, with my own child, yeah, try and go through those food aversions. Yeah, chocolate always worked with her. Drew?
Yeah. So we'll come on to a couple of more specific questions now, and yeah, I'm just listening to the sort of recurring theme, I guess. We found this with this condition is that they're all the kids are just so completely different. So thinking about what might work for them was always the best approach with Benjamin. So yeah, so a couple of really more specific questions. So the next one, our surgeon requested that we try to increase the texture of his food. What is the best way to do this? He's currently on 7 months pouch food.
Yeah, that's not an unusual concern. Is that so? Let's say you want that progress to change to be slow and gradual. You want it to be led by the child as much as possible as well. I think also depending on what the concerns have been in the past, how we approach it, and how what the cautions need to be. How are they managing the current 7-month pouches? Are they managing really, really well, and there are no problems at all? That can give more confidence in moving on. Are they inconsistent kind of managing? And sometimes they can, sometimes they can't, and we can find a pattern in that and use that to help us move forward. And sometimes if we are kind of following the labeled maybe pouches that come like for different ages, there is a stage that's quite tricky with a bit where the lumpy food, so that maybe might be packaged as like a 10-month-old and might feel like the next step, and a lot of the times it is, but it is a particularly tricky stage because it's the lumpy foods. That sensation of that can be difficult. And so you might find that children are fine when it's just textured, and then they're fine with things that have bigger pieces in it. But that middle texture with the lumps can be difficult to manage from a sensory point of view. So it's okay to skip that. We don't have to go through that stage because it can be particularly tricky. But we can maybe modify foods that are soft and mash them down, but I think also always think about keeping it moist, keeping it a little bit runny, so that and as you move forward and just notice how they manage it. You can use vitamin dissolved finger foods to get that new texture in that actually will dissolve very quickly, so has much lower risk of getting stuck. And again, easier said than done, but not to worry if you don't manage the next texture, and that's okay. And get support if you're not sure why they're not managing or how you can move forward.
And on that support point, I mean, as somebody who's definitely not from a medical background, and this might surprise you or might not, in the early days, I can still remember I didn't even realise that a speech and language therapist dealt with this issue. So, I mean, just a simple question, like if people out there, how do people go about getting speech and language therapy help, but other help? How do they go about getting those sorts of referrals involved?
Yeah, so it depends on who's involved in the child's care. So if usually we say go to the GP and ask the GP for a referral, and every community, kind of there are community services based in different boroughs. that have a speech and language therapy team that help with speech and language, but also eating, drinking, and swallowing. If there's a pediatrician involved, then going through the pediatrician. Sometimes even so the health visitor can make referrals. If another therapist is involved, any healthcare professional involved in the care of the child can make a referral to speech and language therapy. And if there happens to be there isn't a service in a specific area, then I always encourage parents to raise that right to the commissioners and say, we need this service. And a lot of families manage to access services that way.
Right. Okay. Thanks, Duncan.
Right. Okay. So the next question is, my son is now 5 and still can't manage food. He eats very little. Any recommendations, and is that normal? My guess will be that's not normal, and certainly need some recommendations.
Yeah, it's tricky, isn't it? Because again, every child is so different, right? It's unique. The combination of what's happening with the function and their experiences and their personality, this combination will be different. So maybe for this particular child, kind of all the history, all of that, and what's happening with them, that is what they can manage, and that is kind of normal for them. And we know it's a tough away, a lifelong condition. And again, that teenagers and adults learn to make adaptations, and maybe this age is still tricky. They don't know how to do that. So again, I'm going to say it's going to depend on the reason. Because if we're saying he eats very little, I wonder if that means that they have a feeding tube, or do they mean that they drink mostly liquids and have little food? Is that because there is a structure or dysmotility reason that doesn't allow them to eat more solid food, or is it that they have more kind of tube feeds and they're not interested in eating and drinking? So thinking about where that what the reason is and what the circumstances are. And also, whilst we're thinking of how we can move forward, balancing that with the need for the nutrition, the physiology of what's happening, and then wanting them to take more food and variety of food, balancing these three things can be very tricky. So thinking about how we balance that, and obviously I'm going to say again, get support, because sometimes it's not that easy.
Yeah. No, that's great. Thank you. I was just going to say, obviously, if the person who's asked that question is on, obviously listening to this webinar, please don't forget, obviously, we've got the quick Q&A where you can type in the questions. So if we haven't quite got any of the questions right, or you need to clarify something, so like you said, if they're actually having bonus meals and tube feeds and things like that, obviously they can type that in, and then obviously we can bring that up, and then obviously help and obviously clarify the questions for you and for them as well. So obviously, if anybody's out there with any questions, please do ask them. Drew?
Yeah, so I think the next one's going to task you there, Maya, with this. So is it, having talked about, every child's different, and I think it's really good. The timing of this question is really good, actually. So how can you tell with toddlers if they're generally just being fussy, not wanting food, or if it's a stricture or other discomfort to be concerned about? So yeah, how do you know? Don't be worried if they don't go for the next texture, or there's a problem. Don't get too stressed about it. But like when should you actually do something about it?
Yeah, absolutely, and not easy to differentiate, is it? Because again, as we said, it's such a tricky age developmentally. I would say you as a parent know their history with eating and drinking, so you can also interpret their behavior. So maybe it might be in the way that you noticed it happening. Is it a change? Is it sudden? Do you notice it as part of general behavior that they're starting to show you? Are they generally fussy? And then what the fussiness is about, is it texture related? Can you notice any pattern? Sometimes writing down what they eat and thinking about like the properties of these things maybe thinking about, okay, I have a list of the things that they eat and a list of things that they don't, and is there a pattern here in the texture? Is it the is it the color? Is it the taste? Is it things that are difficult to chew? Or is it not? And maybe it's just general fussiness. And also sometimes it depends how restricted it is. If it becomes very, very restricted, then it's more than just fussiness. Um, but I think, thinking about all these things, obviously, if you're concerned that something has changed and maybe there's a stricture, then talk to your surgeon and get things assessed to see what might be happening. Um, and in the end, the principles kind of are the same: keeping it positive, reducing the emotional stress around food, using those universal strategies that we talked about, like mealtime routines, and um, kind of not focusing too much on the child being the focus of the meal, make it enjoyable, make food interesting. Um, Things like that you would do in either way, because you want to keep the whole experience in that journey positive whilst you manage these things. Does that make sense? Yeah.
Yeah, thanks. Really helpful, and a good lead into the next one for parents identified that you do need to do something.
Yeah, so obviously the next question is about how long do you actually wait before you when identifying a concern for a stricture and a barium plus, and also they put on here about a VFSS. So you might want to start by explaining what that is to start off with.
Yeah, absolutely. So VFSS is a video fluoroscopic swallow study. And that is a study that uses X-ray basically to look at the function of the swallow. So similar to maybe a barium is more commonly known, but it is very much a very similar procedure. It happens kind of using the same machines. And what we do is, a video fluoroscopy swallow study would be led by speech and language therapists, because looking specifically at the swallow at this stage here. So we would add contrast into food and drink, get the child, if you can get a toddler to do what you ask them to do, have this drink or food while sitting down in a chair, and it's non-invasive, nothing is touching the child, but we take X-ray images from the side, and so we can see the contrast and food and drink moving. So we can see, that can help us see kind of how it moves back whilst they swallow, and what the function of the swallow is and what difficulties they might be having. And the barium usually looks at slightly lower down, so more the esophagus and lower down in the gut and how things are moving. Sometimes we can combine them so that we can look at the swallow, but also look at how it's moving through a stricture or the anastomosis site, and what the motility looks like as well. So it can be useful to try to figure out if there are difficulties that someone's noticing with their child, maybe new coughing or gagging or choking or anything like that. So then we can help look at, by combining these two, where exactly and what the reason is for that happening. So the question was how long?
Yes, how long should you wait between identifying a concern for a stricture and going for, I presume, having a barium meal or...
Yeah. So that really depends on the circumstances, right? So I imagine as a parent as well, if you notice a concern, you kind of need to know, you want to know what's happening. And in terms of like the urgency of it, I think it depends on the impact. So and also what the feeding regime is. And if the concern is identified, how it was identified, was it something, did the child, for example, start coughing and spluttering whilst they're eating and drinking a lot? And that's quite concerning. And then that would be, there's more urgency in that. Are they having all of their nutrition, hydration orally? Well, then there's more impact of it, and we need to manage it quicker. If a child kind of is fully milk fed, for example, or they have tube feeds, is that stricture still impacting their feeding? And then how the concern is manifesting as well. So it can make it more pressing to need to find an answer and manage that. If it's possible to modify the food in the meantime to manage through kind of that concern of the stricture. All of these things usually are considered and then balanced with the access that you might have to these investigations, their availability, etc.
That's great. Thank you. Drew.
Yeah, and there's a similar theme. So quite a long question, this one. So how do you introduce new foods and textures to top babies? We've used the 90-10 method, but haven't had success. Whenever we try something new, our daughter reacts badly, gags, and is sick, which makes the whole feeding experience negative. Following on from that, how many times do we continue to try the new food stroke texture with bad reactions before accepting this is doing more harm to her feeding experiences than good?
That's really hard, isn't it? And talks to all of the things actually that we've been talking about. So really important question in terms of balancing giving the exposure and trying, but balancing it with it being a negative experience. And obviously, I think it's obvious. I'm a big advocate of reducing the negative experiences first and foremost, because then we can get into this more deeply entrenched problem. Then we might want to explore the gagging. Why is that happening? Is it a sensory reaction to the texture? Is she maybe not chewing well enough and trying to swallow? Is it to do with the stricture or the function of the esophagus at the time after she swallows? And obviously, you will address these things slightly differently. And that's one of the approaches that they've tried is kind of maybe more exposure based. Other approaches might be more sensory based. If it's a sensory kind of gagging because of a sensory reaction to the texture, then maybe a sensory based approach might be more successful. But obviously, if there's a functional physical reason, then exposure and sensory approaches are not going to be that helpful, are they? So we need to kind of get to the bottom of that as well. And then keeping the environment and the associations that we have with the food and with this experience positive in general, so that you can protect that trust and that relationship with eating and drinking as you're trying.
Yeah, interesting. I know we went around that cycle. I don't know how many times with Benjamin. I think, as you say, I think you have to sort of, it's like a pendulum. You just have to realize, when it's going too much and then slow down, and then things seem to sort of return back to some degree of normality and then try again. And I think, it's exhausting, but it's a repeated trial and error. The pendulum swings back and forth, and I mean, eventually, I do think you get there, wherever there is. But I definitely think you get improvement. So, Duncan, over to you for the next one.
Yeah, this is a really short question this time. So how do you create an appetite for your child?
Really good and really tricky question. I would say a dietitian probably would be a better in answering this, but it again depends on the reason. So are they do not have an appetite because they're tube fed, or are they just not big eaters? Is the appetite impacted by is it feelings of discomfort related to their eating, like reflux or stricture? And also importantly, is there an impact on their growth and nutrition from that kind of reduced appetite? I would start with speaking to a pediatrician about the concerns to try to figure out these things, and going from there, because it might be about kind of if they're drinking a lot of milk and that's reducing their appetite, then might be about reducing the amount of milk or managing the reflux. But if there's an impact on the nutrition, then we need to explore that a little bit more. Maybe they need supplements from a dietitian, and we need to manage that side of things first. And as I was making food enjoyable and interesting, then hopefully just that helps them enjoy the experience, even if they have mealtime with the family and they're not big eaters, but they can still enjoy the experience. And as long as they're getting their nutrition, then that might be kind of, again, a personality, or that's the type of person they are. But there's a lot to unpick about the reason for that and how to go about it.
Okay, so would you say perhaps if it is that case, then perhaps get a referral to the dietitian. And obviously, like you said at the start, it might be better for them to answer the question, so get a referral to them, and also then you can get that help there.
Yeah, absolutely.
Okay, Drew.
Yeah. So my favourite question on is next. So how can we move away from constantly needing distractions to eat and drink? We have to rely on the TV being on for her to drink anything at all, otherwise she completely refuses. And often we need to have a distraction to eat as well.
Yeah. First thing I'm going to say is be kind to yourself. Self-compassion in these things we're talking about is really important. Change is not easy, and it can sometimes be a difficult journey, and sometimes we do what we need to do at the time because this is how we can get them to have a meal, by using distraction. But if you got to a point where you're ready to move away from that and you want to reduce that, and you maybe don't feel it as needed anymore, it just became more of a habit, then you can do things like modeling, not eating with a screen, maybe in a room without the screen. Make it about the mealtime. We're all sitting together to eat, however it is available. And it's a mealtime rather than like a task that you need to eat. So I'm going to help you get through the task by watching something. Um, uh, and make it a routine. Sometimes I think as well, like you know your child, so you know sometimes if you might remove all the screens and change the routine completely, and that's the approach that works. But with some children, you might need to be very gradual in the change. So you might need to do like a gradual wean off watching TV whilst we're eating. So you might want to do it for one meal time or one maybe bottle feed if that's what they're having. Maybe reduce the time. So starting putting something on towards the end or just the first few minutes of the meal, and then reducing it gradually. Being very clear kind of with the routine as well, using clear phrases, visuals that you repeat and say like finish now, or putting a timer to, like if they're watching something, so when the timer is done, that's finished. Choose programs that are short so it comes to a natural end and you can finish it before you start eating. You might also want to replace the activity of watching TV with something else. So that could be sitting at a table at a meal time, but it could also be and talking more. It can be more interactive. Maybe you're like playing a little bit more with the food, or reading them a book or singing, or so kind of replacing that activity with something else. Very important is to make a plan and be consistent, and make a plan, not just kind of one adult in the house has a plan, that everyone has the same plan and is consistent in what they want to do, and knowing that it's difficult and they might have a tantrum, and what are you going to do about that tantrum? So yeah, making a plan ahead of time.
So I'll just nip in with a follow-up question then to that. So how do you, a lot of the theme is around, having a plan and, trying to introduce routine, etc. How do you balance that with the flexibility that a lot of these children do require because of their condition? Just interested, how do you see that? Because we when Benjamin was younger, did both. We were very regimented actually with lots of things. You'd really find that routine really helped, but equally at times he just needed space and flexibility to do his own thing as well. So how do you get that balance right?
Yeah, and again, like this is so dependent on the child, right, and their personality and how they respond to things, and you might relate it to how you deal with other things in the day and kind of behavior in general, or things that you want them to do, or routines that they have to do through the day, and how they cope with that. So some children really need the routine and need things to be really consistent from a personality point of view and how they respond. And some children, are okay with less routine and more kind of flexibility. So I think it is your child and what they need. And I do think also having routine doesn't mean that we are very rigid and it's exactly the same thing every single day in the same moment. But there are some markers to the routine. So maybe like when we say mealtime routines, like there's a clear start. So maybe they help you set the table. That's their cue for the start of the meal, and they sit down. And there's a cue to finish, which is we're finished, and they help you clear the table as well, or take their plate to the kitchen. So it's not kind of a very rigid thing, but it's just a marker, and that creates a routine for them as well, and to know that. And having kind of, because if you extend it and there's no marker for beginning and end to a meal, it just feels like this is going to go on forever. And I don't know how to deal with it anymore because I don't want to do it. So it becomes more difficult. So I think you can, do both as a parent. You have a routine, but you can be flexible. And you might have a day that's like no routine today because today is a day off and we're not going to follow the routine. And that might work. And maybe for some children you realize or you feel that doesn't work.
Yeah. I think in my world, they'd call that flexibility within a framework. So yeah, sort of the framework idea is really, really clever, I think, rather than that sort of rigid routine. So yeah, very interesting. Thank you. I told you it was my favorite question. Duncan, over to you.
Yeah, I probably could have done with that with Laura for us, because I know the record length of time for a meal was 1.5 hours at one point. So I think patience is also a great virtue in terms of when you're struggling with them to eat and wanting them to eat and just trying to persuade them to eat. So yeah, that was our longest meal ever. So it does take a while to get them to start eating properly. Speaking of eating and drinking, how can this family move away from milk bottle drinking?
So yeah, I wonder if it's about the bottle as like a utensil for drinking, or is it the milk that's the like kind of drinking large amounts of milk?
I think it'd probably be the actual bottle and drinking from the bottle and starting to perhaps go to a cup or.
Yeah. Um, so again, it's we want to balance the developmental aspect of moving away from bottle with like making sure that they're if it's about like also we drink lots of bottles, then like maybe it's impacting how much they eat, with them having their nutrition and hydration. So I would start introducing like spend some time introducing a cup, whatever cup you want to use. And it might be just a little bit, maybe like with meal times there's a cup once a day, and start introducing that. They get used to it. If it's about the if it's about them like they're feeling too full because they're drinking lots of milk, then I think that's you need some guidance maybe from the health visitor dietitian to make sure that there's no nutritional impact from reducing that, to encourage them to eat. Sometimes it's the bottle itself, it's a comfort. So you might want to start replacing it with a different item of comfort, for example. So start with associating it, like every time they have a bottle feed, you introduce a toy or a comfort of any comfort item. And then they kind of pair it with the bottle, and then you can start trying to move away from the bottle and them just having that item or toy. Offering the bottle after it's eaten as well might be helpful, not kind of like when they're hungry or when they wake up. Sometimes there's a routine of like when they wake up they have a bottle, so they're hungry, then they want that bottle and they have lots, and maybe that that impacts the rest of their meals. You can also gradually start restricting bottles to make sleep time and bedtime routine. So it's the bottle is to help us go to sleep, for example. Um, Obviously, this may be a completely different situation if they can't manage food, and that's how they're getting their nutrition, and then that's different, and that's when you definitely want to talk to your nutrition, get support from dietitian. And also you can, if there's an issue with kind of moving on to a cup because of a skill, then that is something that speech and language therapists can support with as well. The skill of drinking from an open cup and making sure that's safe.
Yeah. I remember with Laura, we used to basically have her in a towel. We got an old towel and just cut a hole in the top in the centre so it covered her from head to toe, because she liked to get food everywhere, and then she'd get hold of a cup and then she'd throw it over herself and everything else. So it can be a messy time.
Yeah.
But it's also
That can be sometimes another difficulty, because if people find it difficult to handle messy times, and that's an additional kind of difficulty that you need to deal with.
yeah, we got around it.
You've given me flashbacks on all that question I was on the bottles. You know, the teats that you could get that are like different flow rates.
Yeah.
I mean, I must have had to take out an additional bank loan to finance the amount of different flow teats for bottles that we had in our house at one point in time. And I think you found the right one eventually, but it also sort of depended. And the other thing that I remember back then, actually, that we found worked for us was, the cups with the tops on them that have the little sort of bit that comes up.
Yeah.
And we found obviously various different types of those with different sized holes.
Yeah.
And they all had a slightly different flow rate as well. So I can remember there was one of those that just like seemed to reappear. It was in the house for like, probably the best part of 5 years. So experimentation. So
Yeah, absolutely. And those are popular because it looks like a cup with that rim, but it has a lid so it doesn't spill. And they do need to do a little bit of sucking. The other thing is, like, it might be that comfort of sucking. And sometimes like children get stuck on needing that before they go to sleep, but you can replace it maybe with something else, like drinking from a straw, sitting up in the bed, having something from a straw, and then going to sleep, for example. Exploring different.
was insistent that we'd never use a dummy. And then obviously we had a tough child. And we found with him that he had, for various reasons, he had quite bad reflux. So we actually used the dummy quite a lot at feeding times, but not necessarily while feeding, but afterwards. Dummy really worked to keep the swallow reflex going, to try to prevent, as much reflux.
Absolutely. That sucking motion helps.
Yeah. And so just want to mention the Q&A chat again. We've had one question come in on the Q&A, but don't be shy, because we'll have a bit more time. We've got one more question to go, and then we'll have a bit more time to answer any other questions. So by all means, float any other questions in there if people listening want to. So then the last question on our question list: how do you get a baby to use cutlery?
So I wonder if this is a kind of developmentally just introduced to cutlery, or is there a barrier here? Is there a difficulty that they're maybe not wanting to, refusing, or don't like it, or but again, like everything else, like breaking down, understand more what's happening there. I think also thinking of your priorities. Is it maybe a social or a cultural kind of a requirement that we want them to use the cutlery, or is it about their skill development and they're not managing, or is there an ability kind of with coordinating that? Is that the issue? I think if we're starting from the beginning, it's usually you want exposure, you want to model, or you want the opportunity for them to try. Starting with letting them explore by having when we start weaning, for example, I say, like, let them hold a spoon themselves, and you can help feed them with the other spoon. Then they can start bringing that spoon to their mouth and learning that. And you can dip the spoon for them, and they can bring it in. So they start already just not very coordinated, will go everywhere. But it start that kind of association, movement, and coordination, doing hand over hand, some practice, fun activities, using it as well. Sorry, not worrying about the mess, which is hard. But I think also sometimes maybe there is some fear, right, around introducing self-feeding, maybe around, because we have concerns or anxieties around like the feeding experience and how much goes in and if that's going to be okay, are they going to manage it and all of that. So I think if that's a concern, then thinking of ways that can reduce the risk that you're worried about, whilst as well giving the opportunity to practice and get that activity in and play with it. And if it's a coordination difficulty and ability to self-feed, then our wonderful occupational therapists are great at helping with that skill and like kind of all of those daily activity skills.
Great. Really interesting. So that's the end of our pre-prepared list, Duncan. So I know we've had another question come through as well in the chat. So Dan, do you want to take the first one and then I'll do the next one, and then probably still got a few more minutes, so if people put other questions they want to pile in with on there, that's great.
Absolutely. So the first question we've had put on by somebody attending tonight is, our 2.5-year-old is tube fed into jejunostomy after a gastric pull-up. He's currently nothing by mouth other than small sips of water. How do we find the balance between prompting him and encouraging him to eat, but then also not pressurizing him or leaving him to explore in his own time? We found that neither approach to be successful and they're feeling a bit lost.
That's a really good question. There's a lot there, and it's not easy. I think that those are one of the times that we want to understand kind of from your multidisciplinary professionals involved. So I would assume there's a gastroenterologist involved if it's if it's jejunal feeding, or at least a pediatrician. So talking to them about what they can have in their stomach if we are bypassing that. So water, sometimes we just use water because that's they can manage that in the stomach and they can tolerate it, but maybe they can't tolerate something else. So starting there and talking about that, hopefully there is a team around the child as well, with a dietitian, usually if they are judge-fed as well, and hopefully a speech and language therapist as well. So definitely talking to them about a plan, and how to introduce things and what to introduce. Sometimes there are specific things that they might advise from that point of view. And then you have multiple considerations. You have considerations about the texture, but also what the components of the food that they are able to tolerate in their stomach. And then balancing the encouragement and the prompting and not pressuring is really, really hard. I think I would always go with more of the let them explore at their own time, because the pressure is unlikely to help. It's likely to just add one more difficulty to the situation if there's a lot of pressure and focus on the eating. So trying as hard as it is, lower the emotional load of that activity, and allowing them to explore more. And it's a lot for them to explore because this is not an experience that their body is used to, or their in their skills, and it's not easy. And I understand that they feel lost. I'm sorry.
Thank you.
Great. Yeah, and so the other question that we've had in from one of the attendees, my 14-month-old has been peg fed since surgery 1 year ago. On a good day, he's interested in exploring finger foods or licks a spoon here and there. How can I inspire him to eat more volume now that it seems to be working?
That's great. So lovely that they're exploring finger foods, doing licks and spoon. That's a really, really good start, and that's probably the hardest bit to get to. And then if so they're 14 months and have a peg. So it might be, if they are accepting a little bit of puree, for example, or whatever is on the spoon, some finger foods, you might want to start talking to the dietitian about if they can have less peg feeds so that they can have more hunger cues. It depends also on the regime. So if they are on bolus feeds, then it's a little bit easier for them to have that hunger cycle, and be more interested in eating. Are they a good weight? Are there concerns about weight, or are we happy with that? And they might explore with you ways of doing, maybe spacing out the feeds a little bit more, so there's more time for them to feel hungry and interested, reducing slightly. It might be very, very gradual. Sometimes you're reducing very, very slightly, but definitely need to work closely with dietitian, speech and language therapist if there are skill concerns or swallow concerns as well. So that's I would probably start there. Again, all of the things that we talked about in terms of meal times and enjoying that, and kind of just reducing the pressure will also help.
Yeah. I know.
Sometimes as well, sorry, at that age, actually, peer pressure, not peer pressure, but peer support. Some children you notice that maybe they're not really interested in eating at home, because this is kind of the routine they got into. This is what you're used to. As soon as they're in a different setting, like a children's group, a community children's group, or a nursery, and they sit around a table with other toddlers, they might be more interested and copy them and eat a little bit more. So if you have opportunity to join groups like that where they can kind of sit with other children, that's really helpful.
Yeah, that's a really good idea. So Dunkirk, any other ones come up on the?
Yeah, I was just about to say I'll do that one. How do you teach the rotary chew? This person, they've currently got a 6 to 7 month year old who I was eating 6 to 7 month old pouches, and with occasional bite and dissolve, but the child is actually 20 months old, and they're just struggling to getting that progression of texture is also being hindered. I mean, one of the things that we found extremely useful, it was the best thing we ever bought was a potato ricer for foods, and then starting to introduce, because you got lots of different sizes of blades with it, so you could then introduce more texture. That seemed to work for us, and that was our godsend, because I mean, Laura had nearly 30 operations to widen her stricture, so because it was extremely narrow, so we were stuck up a bit like this on really thin food for a long time.
Yeah, that's really advice.
Yeah, but I'm interested about the rotary tube.
Yeah. So practice by and using, they have occasional bite and dissolve. That's good. That starts kind of like that bite and beginning of that chew motion. What you probably want to do from there is introduce that bite and dissolve finger food on both sides. So first on this side, then on this side. So let's go back and talk about rotary chew. The way that what we do when we're chewing, we don't really think about this, but what we're doing is moving the tongue side to side. So moving the food from one side of the mouth to the other, and chewing at the same time. So that's the motion that we want going to teach or practice chewing. So you want to encourage the tongue to move the food from side to side. So if you're using a bite and dissolve finger foods, for example, one bite here, that encourages the tongue to move and get the food from the side of the mouth. If you're using like 7-month pouches that are a bit textured, you can do the same. You can put 1 spoonful on this side, 1 spoonful on that side, and that will encourage that movement. So I would start there.
Didn't know about that. Never thought about the rotary chew and things like that. So
I didn't even know what the rotary chew was, so I didn't know. Is it a new thing that wasn't around when we sort of had Benjamin as a youngster, or I didn't even know what the rotary chew was?
Yeah, and it's just a term to describe what we kind of mature chewing is like. That's a motion, because you can have initially when children learn to chew, they're doing more of a kind of an upward and downward movement without that motion moving around. So it's just the motion of chewing that is more mature, basically.
And then I guess just quickly before we do the wrap up, and I'll just do the bit of housekeeping at the end in the last minute or two. But what is your view on sort of use of dummies? In the context of feeding, because we
Yeah.
we met speech and language therapists, way back who had differing views actually on it. So yeah, it's personal to me maybe, but I'm sure there's probably used dummies as well. So
Yeah, it's a good question. And actually, we could get asked this a lot, especially because I work on a neonatal unit. So obviously, parents have kind of sometimes an idea of what they want to do, and then things change because the journey is different to what they were expecting. And so then the question is, but do we introduce a dummy because we thought that wasn't good? So it depends. So I think the reasons that dummies are maybe not liked are get kind of children getting stuck on a dummy and having a dummy until they're older, and how that can impact the development of their mouth. And the other thing is when it interrupts feeding cues. So if a dummy is used for like a baby showing hunger cues, and instead of getting feeding, they get a dummy. So that can kind of change, just interrupt those cues, especially if they are it's just establishing oral feeding, maybe establishing breastfeeding or establishing oral feeding. So those are kind of the two main reasons. But with children and babies that we're thinking about in this context, there's lots of other things going on with them. And actually what we want the dummy for is two things: having positive experiences orally if they're not able to feed yet, and then also practicing that skill of sucking, which is what they need to do for feeding in that stage. So if they can't have oral feeds for structural reason, they're still waiting after surgery, etc. Then you want them to have an experience that is first positive, then they're practicing that skill. And sucking is something that also, we can practice and improve with practice. So it becomes quite important and essential. And it's not kind of used more for like to quiet the baby because the baby's crying. It's actually being used for other reasons.
yeah, makes
Does
sense.
that answer your question? Yeah.
Yeah, it makes sense. So we've got one more question that's come through on the Q&A. So we'll just do this one quickly, and then I'll do the wrap up. So yeah, so what one big barrier to our child beginning his journey in feeding seems to be a sensitive gag reflex to food, though not to anything else he puts in his mouth. He will occasionally try to taste something that has an immediate gag, which clearly puts him off. Anything we can do to counter this?
Yeah, good. That's a good question. So, I wonder if this may be, or sometimes this is related to things like lots of reflux. If a child has lots of reflux or vomiting, they might have a hypersensitive gag, and then that makes things more difficult to move on from, because you're constantly getting that kind of reaction, and you don't want to perpetrate it. So maybe trying to see if there's anything that we can manage from that point of view. And then if it's kind of when he tries to taste something, then is there something about that specific food or taste or flavor or smell that it's particularly strong? Because if this is a sensory reaction, the gag is a sensory reaction, then maybe the sensory properties of something are very strong for them, and maybe we just need to reduce that. The taste being kind of less strong, or the smell, or the texture. It might be that the texture kind of gets that response. So trying to think of that, and then how kind of that's introduced as well. A lot of children are fine if they are the ones putting something in their mouth, but as soon as someone else is doing it, that's when you get that reaction. So if it's possible for the child himself to do this and bring things to his mouth, it sounds like he mouths other things that are not food, which is we hear all the time as well. Then if that means that they can mouth an empty spoon and they're happy to kind of chew on it, then are they happy to have a dip of something on it, but maybe thinking of something that it might be something bland or in taste and smell, and not too textured. Maybe it's quite runny initially, maybe just liquid initially, and then building up from there.
Really helpful. Thank you. Right, so we're just past 8 o'clock, so we'll wrap up now, and then this is the important bit, obviously. So to say thank you to you, Maya. Really interesting. I think we could probably talk about it for many more hours. And thanks. Really appreciate your time and some really interesting insights. So thank you.
Thank you, and thank you for all the questions. They're really great. Yeah, thank you.